Hello and welcome to Conversations with Dr. Bachner. Once again, it is Howard Bachner, Editor-in-Chief of JAMA. I'm delighted to be joined by Carlos del Rio. Carlos is a member of our editorial board, a distinguished professor of medicine at Emory, where he's also an executive associate dean, and a member of the infectious disease group. The other guest today is Preeti Malani. Preeti is an associate editor, chief health officer at the University of Michigan, where she's also a professor of medicine in the School of Medicine. Carlos and Preeti, welcome.
Happy to be with you.
It's early March, almost a year from the huge, extraordinary march of disease across the world, from China to Europe to the United States to the rest of the globe. Carlos, before we get into your viewpoint that you've written with Preeti, I think it's I was trying to figure out, is your fifth one? It's these like six bi-monthly updates, so I enjoy it. But before we get into it, because it's set up like the others as questions all around vaccines, Carlos, it's been a year. Your impressions?
Well, I've reflected, Howard, a lot of what has happened over the past year. The first thing I would say is I don't think any of us in our most wildest dreams would have even think about the devastation that we've seen as a result of this pandemic, both in terms of human loss, over 500,000 people dead in this country, in terms of economic loss, but I think also we would have never predicted that we would have effective vaccines so quickly, and that we would be, as of today, with over 100 million shots given globally. So I'm in the United States. So I'm at a point of guarded optimism. I have still a lot of concern that a lot needs to happen, but I'm optimistic that science is getting us out of this pandemic. We still going to need a lot of work globally, though. I mean, we have millions and 300. Preeti and I were talking 300 million doses roughly given globally, and that's 100 million in this country. So the reality is many countries have not even started to vaccinate their healthcare workers and the most essential workers. So we have a long way to go. And I think there's going to be sort of this year, in my mind, is going to be the year of really thinking about global collaboration and cooperation and how do we work globally to actually end this pandemic, not just locally.
Preeti, when you think back the last year, you saw all the papers with me. You helped. They all came to me, and I'd send out my emails. Preeti, help. What do you think? To you and a few other people. When you look back over the last year, Preeti, what's your impression, your reflections?
Howard, a lot of the same things that Carlos said. For me, I think the interesting thing is how quickly it changes. Even this viewpoint, which came out a couple of weeks ago, 10 days ago, what we know in the morning changes in the evening. And I think it's an interesting place to be. And, for me, a lot of my perspective has been the campus and trying to get students back to face-to-face learning and all the benefits of that. And, what I would say is that a year ago, it was only about viral transmission. Nothing else mattered. And it was like we just closed the light, shut the door, and sent everyone home. And, getting back has been really complicated. And, at some point, the virus is going to be in the background. It can't be everything. And we're going to have to live with some residual risk. And we're going to have to cooperate and trust in science and sort of take care of each other. But it's a remarkable year. And I think it's, for a lot of people, students, healthcare workers, everyone, this is an emotional month. When you think, wow, it's been a year since we were, quote, normal.
Yeah. And I think that's the one thing that I do worry about is that there's going to be post-pandemic PTSD, and the mental health consequences of this pandemic are not trivial, and it's something that I think as a society we're going to have to really work hard at.
Yeah, I think, we had a piece by Charlie Marmar and others that talked about the psychological consequences, harm, challenges of 500,000 deaths and a year of just total disruption to what life is like, and what that will mean over the course of the next few years. I'd like to turn to the viewpoint, work our way through the questions. I'm sure others will come up. feel free to banter between the two of you if you'd like. Preeti, I'll start with you. Moderna, Pfizer, J&J, I always think of them as the Band-Aid company, Johnson & Johnson, which is the same as the Janssen vaccine. People sometimes get confused. So Moderna, Pfizer, J&J, Janssen, which vaccine, Preeti, are you recommending?
Yeah, and I've heard it called Janssen. If
Janssen.
You want to really,
so I may be mispronouncing it.
just to confuse it. So Howard, whatever vaccine you can get into people's arms, and I think this is a really important question. Not just for healthcare workers. A lot of us have been vaccinated. For me, there wasn't a choice. It was Pfizer, partly because we had the -80 freezers on site. For everyone else, I'm like, whatever you can get, whenever you can get it, as soon as you're eligible. A lot of focus that I'm hearing is, this vaccine efficacy and this, and all of them work beautifully with severe disease. And that notion of vaccine efficacy, and I know Carlos can talk about this some more too, but I worry that the public is taking those numbers and comparing them the way you might compare another number. And that's not at all what those are. The 60% doesn't mean you have a 40% risk of getting COVID. And so I think, again, I frankly think the Johnson & Johnson or a Janssen vaccine has a lot of advantages as a single shot, particularly in younger people who might be mobile and might not want to come back for a second dose.
Carlos, any vaccine preference?
I have no vaccine preference. I agree with Preeti, but I also I want to add that we know that people that already had COVID may not need 2 doses. We're still recommending 2 doses of those vaccines that are 2-dose vaccines like Pfizer and Moderna. But in somebody who's already have COVID, young people who already had COVID, probably Janssen, the Johnson & Johnson vaccine may be great. You get 1 shot and you're done. So I think what we need to go now is we are done. Well, we have data on efficacy. Now we need to move to effectiveness. Now we need to really look at population level effectiveness. And that may be totally different. And I think getting that movement from efficacy to effectiveness is something that we need to get the population to understand. And if you get a vaccine, you get some effectiveness, especially when you start talking about herd immunity and other things, other benefits. If you get no vaccines, your vaccine efficacy may be 95%, but your effectiveness is 0 because you still haven't gotten the vaccine. So any vaccine is better than no vaccine.
Not surprising. The first question has already come in. I'm not surprised. It's interesting. About a month ago, we must have gotten 10 papers on variants. Then the last week or two, it's been just a little quieter about the various variants. Carlos, anything new about the variants? Is it just continuing to churn or evolve, and it's really hard to get very specific information about the different variants?
Well, first of all, as you know, RNA viruses tend to mutate, so we're going to be seeing variants. But I think I heard the other day, I think Monica Gandhi or somebody talk about we need to stop calling them variants and hear them and talk about them as scariants. People are getting scared by them, and there's not need to just use this to get scared about things. We know certain things, and I think the one that I'm more concerned about, honestly, is the UK variant, because we know it's more transmissible. It's probably going to be the dominant variant in our country by the end of March. So I think it's just a reminder that what we need to do is shut down transmission. And how do we do that? We do it with vaccination. We do it with masking. We do it with social distance. Because if we stop transmission, we stop viral replication, we stop variants from occurring. So to me, variants serve me as a reminder to tell people this is not over. I was telling a group the other day, I feel like we're landing the plane, right? And we had a very rough takeoff. We want to be sure that the landing is smooth. And when you're landing a plane, the captain doesn't say, "Oh, we're almost there. Take off your seatbelt. We're fine. No problem." That's what I'm hearing a lot of governors say. "Oh, we're almost there. Take off your mask. Go up in the state. We're done." We want to be sure that we land successfully and we end up this problem. And we have to, and I think the variants are a good, in my mind, a good opportunity to talk about why we need to continue to practice non-pharmacological interventions while we vaccinate everybody.
The very second Q&A your viewpoint is entitled, "Do Vaccines Protect Against Infection and Prevent Transmission?" Preeti, this is all yours because this is
Yeah.
so confusing to people.
Yeah, and I think the one thing is that these are difficult things to ascertain quickly, and part of it is we just need to see. And I would say the data from Israel is really encouraging, and I know Carlos knows the data well. It's encouraging both in terms of variants with B117 circulating widely there, and today, this morning, actually, the New York Times Daily talked about Israel and the fact that they've done a really good job, at least within Israel proper, of vaccinating a lot of people. And they're back to a lot of pre-pandemic activities. And, I would say that there's at least a suggestion that infectivity, if it is there, is low. And, in our viewpoint, we said it's unknown. But I don't think anyone feels like it's going to be exactly the same. It'll be less, and maybe it'll be very low or zero.
Well, it's a little bit like what we were talking about, right, Preeti? We wrote this 10 days ago, and there's already new data. When we wrote this, we said we don't know. Now we have better data. There's some very nice data showing that even if you get infected, the amount of virus in the nose, the production of virus is a lot lower. So you may be less infectious. So what we need to know is what happens. Again, I think we need a lot more population studies to really understand this. But I feel better today saying this vaccine is likely protect against infection, likely protect against transmission. And even if you get infected, you may not produce enough virus to really make it a difference. So I think it's amazing that these vaccines are actually doing that. And the data from Israel, you're right, is great.
I'm not sure we're going to get through the viewpoint because there's so many questions. So I'm going to bounce back and forth. I'm not surprised, and I'm quite.
Well, people can read the viewpoint.
They can read the viewpoint. That's true, and I can ask the questions. I'm not surprised. Oxford, AstraZeneca news from across the pond. Could both of you reflect on it? Carlos, I'll start with you.
Well, I mean, I first reflect by saying I want to look at the data, right? Because I haven't seen the data. I want to see data because I tend to be data driven. Having said that, when you're vaccinating millions of people and you start seeing things in the background, you need to pause for a second and say, is this association or is this just causation? And, association doesn't mean causations. At this point in time, there's millions of people who have received the vaccine. There's a few events that have been reported. And we need to look at it. I want to see the data. I'm not yet convinced that there's an association. So I am still recommending that people receive the AstraZeneca vaccine in places where the vaccine is available. I think the risk of getting a thrombotic event is much, much lower than the risk of getting, for example, COVID in countries like Mexico, Brazil, and others who are actually vaccinating using precisely that vaccine. So in fact, today, I recommended to a friend in Mexico to go ahead and get vaccinated.
Were you surprised how many countries have so quickly suspended use of the vaccine? That when I picked up the newspaper, by the afternoon, I think 3 or 4 more countries had suspended use. Is it because they're concerned about only then increasing vaccine uncertainty? Yeah,
I can weigh in on that. I think as we were sitting here, my alerts were going off that Germany's also paused it, and with a new vaccine, that hesitancy and those concerns do have to be taken into account. And you don't want to undermine confidence, but I agree with Carlos that when you talk about 17 million, 20 million, 50 million people getting vaccines, you're going to see certain things. And then, you just have to stop, pause, look at the data, share data. But the AstraZeneca vaccine is something that worldwide, this is expected to become, produced in the billions, with the B. And because of its cost and because of its temperature stability, this is the vaccine that's going to really be used everywhere. So it is important to ascertain that. But all of this is in the backdrop of the risk of COVID. And if there happens to be a slightly elevated risk of thrombosis, and I don't think anyone knows that right now, it may be that this is completely nothing association. It wasn't seen in the earlier studies. That still can be weighed and looked for and prevented. So I think, frankly, we're a little bit, we're sort of surprised that we have multiple safe, highly effective vaccines. I don't think anyone expected that. I mean, we would have accepted, less effectiveness. We would have accepted potentially even some safety things. So hopefully it's good news, and hopefully it's just for a short time that we're paused.
Preeti, I want you to take the next question because it's permeating U.S. society as schools reenter and reopen. And as I said, you're chief health officer at the University of Michigan. I don't know, 50,000 students. The distance, 3 feet versus 6 feet, and ventilation within rooms. Now, this has become a really major focus for K through 12, but I can't imagine on a college campus that this is not an issue. Can you comment? It's a question about this 3 feet versus 6 feet.
Yeah, I would love to comment on that. So one thing I would say is last fall, we didn't really know how a lot of this was going to turn out. And one thing that's been very consistent, K through 12 and the higher education space, is that classrooms are safe with mitigation. And by that, I mean masks more than anything, making sure people who are sick stay home. We actually on campus are doing routine surveillance testing. We weren't doing that when we started, but that was something we were able to ramp up. Now in classrooms across the country, teachers are being vaccinated, fortunately. And in my community, most of them, anyone who's been wanting to get vaccinated pretty much is now, which is not the case a few weeks ago. So that's good news. And this 3 feet versus 6, when you think about 6 feet and what that's based on, this is based on like sort of old data models, how do droplets function? It's not like at 5 feet, the droplets fall on you and at 6 feet, they don't. All of it's a continuum and all of it is a little bit practical. Now, there are a number of classrooms that are closer to 3 feet than 6 feet, and they have been okay. And one of the studies that came out earlier this week, Howard, was in clinical infectious diseases. This is from Massachusetts, and they looked at this in your home state, still your home state, I guess. But they actually found that there wasn't if they could ensure masking and good ventilation, that the 3 feet was acceptable. And I know Carlos and I were chatting about this. Is that the hope is that the CDC is going to follow up with a more formal recommendation in this regard. But my sense is that moving forward, as we have lower incidence of infection and we have more and more people vaccinated, especially if we can ensure good adherence with masking, that we can probably decrease that 6 feet distance.
Carlos, this question comes up all the time, and it's interesting. Someone I'm glad to see is reading JAMA. We published an article, a research letter, Immunogenicity of a Single Dose of SARS-CoV-2 Messenger RNA Vaccine in Solid Organ Transplant Recipients. I think every time I do a podcast around vaccines, people who are immunocompromised in many different ways have said, can you talk to the millions of people in the United States that are immunocompromised? And they're immunocompromised in different ways: drugs, chemotherapy, underlying disease. Can you talk about vaccines in immunocompromised adults, or is it so heterogeneous that it's hard to make a definitive statement?
It's very hard, Howard, to make a definitive statement. But at the same time, we know from different data that people who are immunocompromised and with certain conditions, they're at particularly high risk of COVID. And there is no problem with them receiving the vaccine. There may be an issue as far as side effects. There may be an issue they may not respond as effectively to the vaccine. And that is my biggest concern. So I tell people get immunized, but you need to be careful. I mean, if you happen to be on a monoclonal antibody that wipes out your B cells, or if you happen to have, a lymphoma or something that in which your B cells are not as effective, you may not respond to the vaccine in the way somebody else would respond. So the protection you get from the vaccine will be very different. And again, that's where we need the studies of saying, do this vaccine actually protect people who are immunocompromised? So I see no reason to tell them not to use the vaccine, but I see not enough data to tell me, yes, and once you're vaccinated, you're good to go. You're going to be protected, because we didn't enroll those people in the clinical trials.
Preeti, it's diseases a year ago. Are we out far enough yet? Vaccine trials started in July. We know that people were infected all through last fall. Do we have enough information about how long protection, although it's poorly measured because it's often just neutralizing antibodies, and so we don't have a very good assay for T and B cell memory. are we beginning to have a sense about how long immunity will last, either from the vaccines or from a naturally acquired disease?
This is a good question, Howard. And, I would say that we still are uncertain. I mean, partly because the early cases, we didn't even know a lot of people who were infected unless they were really sick and in the hospital. But there was clearly a lot of transmission in the community. And, so far the vaccines, it's unclear. What will happen is we'll get everyone vaccinated. Hopefully we'll get good numbers. And then we'll see if we start seeing increases in infections in people who've been vaccinated. And we are seeing a few of those. A lot of what we're seeing are people getting routine screening before a procedure, for example, or when they get hospitalized for something else. We're not seeing a lot of symptomatic infection, which is encouraging. As you note, neutralizing antibodies, I mean, that's one correlate of immunity, but there are many more that are hard to measure. So I'm hopeful, but if I had to guess, we're probably going to look at some sort of booster next year.
Vaccines become more widely available. I think, Carlos, you mentioned 100 million doses given. As of this morning, I know all of the last 2 weeks or last 10 days, it's been almost 2 million doses a day. Any deviation from the 3 and 4 week plan from Moderna and Pfizer, or are both of you supportive of the current EUA and recommendations from the CDC?
I tend to be supportive that, use medicines as they were studied, as they were prescribed. I also do tell people that if you need to wait a little longer for whatever reason, then that's not a problem. You can still get your vaccine, get your second dose, as soon as you can. If it's not, if it's Pfizer, it's not at 21 days, it's 27, 28, 30, you're fine. I mean, nothing is going to happen, but get your second dose. I think it's going to be very important that you still do that, because precisely what Preeti was saying, we don't know how long your protection will last, and we do know that booster event actually raises significantly, at least our neutralizing antibody levels.
There's a number of other questions, but I wanted to touch on 2 issues, and then we'll go back to some of the questions. Vaccine hesitancy and equity in distribution. It's been a struggle in the United States, more pronounced in some areas than others. I saw Massachusetts data this morning about the Latinx community, the least vaccinated community in Massachusetts. Massachusetts had finally caught up and now exceeded the national average for the percent vaccinated, although it was very slow going. The technologically dependent approach to vaccination created a lot of struggles for certain communities that are not technologically as intense as other communities. Do either of you have thoughts about this persistent problem?
I mean, as you said, we made it complicated, right? You made it complicated to get vaccinated, and by having to go to a website and sign up and do this, and then there's this problem that we create of scarcity. So you have millions of people who want to get a vaccine. As I think Governor Cuomo said, we have 10 million people chasing 40,000 vaccines every day. I mean, I think that creates a problem, right? So the people that are more savvy are going to get them. The people that are going to be out there are going to get them. I think you really need to do certain approaches. I think DC has an interesting approach in which they went by zip codes. They went by specific areas, and they went to the most, needed area. And they said, we're going to vaccinate you. In order to get vaccinated, you got to live in that zip code. You cannot be traveling from a different zip code because, for example, in New York, when they put vaccination site in the Bronx, it was people from the Upper East Side that were driving out there to get their vaccine. We need to be sure that we're intentional. We need to be sure we're specific. We need to make it easy. For example, at where I work at Grady Hospital, when we realized very quickly that having people make appointments just made it complicated. Make it open access so people can just show up and get their vaccine. If they're here for clinic, just have them go downstairs, get their vaccine. So you've got to make it a lot easier. But we also have to work with trusted messengers in the community. So if a trusted place for you to get your things is the church, let's work with the church. If your trusted places, for example, this weekend I'm working with Latin American Association here in Atlanta, vaccinating people over there, because that's a place where they go for multiple services. It's a trusted place. So let's put the vaccinated side there rather than having them get in a bus or getting transportation and go to a place that they are not familiar with, which is the hospital or the health department, to get a vaccine. Many of them have never been to the health department, and now we need to tell them you need to go there, get your vaccine. So how do we make it easy? How do we make it accessible to people? And I think access and trust is really critical in achieving this goal.
I didn't see the interview over the weekend that Tony Fauci gave, but it was about a certain group of Republicans who didn't want to be vaccinated. And I think the quote I saw, "I just don't understand this." Preeti, I'll let you comment on, my sense of vaccine acceptance has gone up. I mean, we watch the polls. It's 50%, 55%, 60%, 65%, 70%. And then you have groups that just refuse to be vaccinated. Is there a way forward?
Yeah, I hope there is. And, again, just to follow on Carlos's comments, vaccine hesitancy is not one thing. And, we sort of label certain communities. And I think these are really important measures. And for example, Detroit's going to have a big site at Ford Field with FEMA where there's going to be incremental vaccine 7 days a week for 8 weeks straight. But, we're not talking as much about hesitancy in rural communities and among more conservative voters. And frankly, those groups probably have more hesitancy than some of the communities that we think of in urban areas. And I think getting at the reasons for hesitancy, one thing that we found in some of the work I did with the National Poll on Healthy Aging is that people really trusted their doctor's recommendation. And I think it gets at what Carlos said is like, when people come for the regular appointment, try to make it easy for them to come to get their vaccine. I know that some hospitals are also vaccinating people as they're being discharged, but it really comes down to having those lengthy conversations with someone who's trusted. Because if you don't believe that the virus is real, or everyone around you doesn't believe this is real, you may not want to go get this. The other thing is, if you don't see any benefit to this, I get vaccinated with this experimental vaccine and I still got to wear a mask and I still can't go anywhere. So I think we need to have all those types of conversations and also continue to show people the way forward.
Well, that I think gets to an issue in our viewpoint, right? We actually put recommendations of what to do if you've been fully vaccinated ahead of the CDC recommendations. Right. And I was very pleased because when I showed our viewpoint to colleagues at CDC, one of them said, "Did somebody leak our recommendations to you?" Because they were very aligned. But it was really important that, as Preeti said, that we tell people what can you do if you get vaccinated, because to tell people the things they cannot do, but yes, you still need to get vaccinated, but everything is going to be the same, is not going to get people vaccinated. You really have to give people some positive things as a result of vaccination. Because, if you're 65 or older, being told you're not going to die sounds like a good benefit, right? But if you're 20 or 30 or 35, and you're told, well, you're going to get vaccinated and your life is not going to change, well, why should I get vaccinated? Because most people my age that get COVID have no problem, right? So I think certain things are going to be important to tell people. And I think as we know more, telling people the kinds of things you can do if you've been vaccinated. I mean, the idea that, you can gather in small groups without wearing a mask indoors is fantastic. I mean, I think all of us really are very happy to hear that.
Yeah, I was going to ask, don't leave me hanging, Carlos, but I'll give you a personal experience. So I saw my brother, my nephew, and my sister-in-law this weekend. Josh kept his distance, but my brother and sister-in-law were both vaccinated. No masks, in a house, having a conversation, having a meal, the first time in 6 months. And it felt normal, that there was a sense of normal. But don't leave me hanging. So what are the other things that you and the CDC now recommend that vaccinated people can do?
Well, I am recommending things that the CDC has not recommended. CDC continues saying don't travel. And as you know, this past weekend was the weekend that had the highest number of travelers going through our airports. So Rochelle Walensky said she was pleading with Americans, to be careful. But spring break is coming, so we got to tell people how to travel. We have to tell people what to do if you've been vaccinated, what kinds of things you can do, whether you need to continue. For example, I travel and I'm not wearing an N95, but I'm wearing a cloth mask, and I'm not wearing any more a face shield on a plane, but I still wear my glasses. I still get, tested before I travel and after I travel. But there's certain things, a sense of feeling a little more relaxed when I travel. There's some things you can tell, and I think telling people, yes, it's a lot. You can travel if you've been fully vaccinated, wear a mask, etc. But it's going to be safe to get on public transportation. It's going to be safe to, get on a subway, etc. by wearing your mask. I think there's certain things that around travel that I think is going to be really important that they tell us what to do soon, because continue telling people not to travel is not going to help us. People are just not listening.
Preeti,
I would just.
Well, I was going to ask. I'm going to ask you specifically because you get to advise the president of the University of Michigan about what 50,000 people can do. So, like on a college campus, what does vaccination mean?
Yeah. So right now, our students are not highly vaccinated. We have the ones in health sciences, and then a handful of others. And this semester, we're mostly remote, but our campus is full. Like we've got kids everywhere, including my own kid is on campus, but they're not in classrooms very much. And my message, this kind of builds on what Carlos was saying. A lot of it for vaccination. One thing is they don't have to be quarantined now. We are still doing routine testing on people, but that's a discussion we're having right now, especially in light of athletics. And I know both Carlos and I, he advises NCAA, I advise the Big Ten. This is something as we move forward, we're going to have less COVID defined, and especially after we get vaccinated. So I think the testing is going to change. Right now, it's still in place. But I also take kind of a view of instead of saying you can't do anything, what can you do? We can't have an abstinence only view on this, particularly with young people. And so what I talk about a lot with the president and with the students is stay in your groups as much as you can, stay outside as much as you can, and if you go home, please don't take COVID with you. I worry a lot about the students going back and forth because there's not enough to do on campus, frankly. So, I think we're moving, right now it's March Madness, Michigan #1 seed. And also it's St. Patrick's Day. These are high risk times. I think we also need to remember that COVID is not the only risk in our life and that all the other risks need to be balanced with this. And frankly, there's a risk of you not interacting and not going to a party. So I think it is very much a balancing act, but we need to keep the community safe. We need to keep our faculty and staff safe. We need to keep anyone else vulnerable safe.
I have one more question here, and then I want to transition to the last. I'm conscious of your time. There's been a number of questions about myocarditis following the second shot. I have not seen any of these reports. But 3 or 4 questions have come in. I don't know if it's linked to one particular vaccine or not. Could either of you comment on that?
I have not seen the data either. I'm hearing it for the first time. I think about association, right? I mean, when you're vaccinating millions and millions of people like we've done, 100 million people, there may be 1 or 2 episodes of myocarditis here, and somebody's going to say, well, this person just got vaccinated. Well, but they're true, not related. So I think this is why we need to be very careful. This is why, following cohorts, following individuals, doing science, doing research actually is what matters, because at the end of the day, the clinical trials, as big as they were, allow you to pick big issues, things that are very common. But if this is something that is going to occur, 1 in a million or something like that, you may not pick it until you vaccinate millions of people. So I would say whenever there's a signal like this, as Preeti said before, be vigilant, be ready to study it, but take it, with a grain of salt until you have really understood what's going on.
Preeti, have you seen any of these reports?
No, I haven't. And the first thing that popped in my mind was the myocarditis post-COVID that we were concerned about, and JAMA's had a number of papers on that. And even that is actually sort of, as they're getting more data, it's not clear that that's as big of a concern. So I have not heard that, and I'd be interested in learning more.
I want to finish with a major transition. Just over the last couple weeks, for the first time, I think there's been much more talk about the global effort to vaccinate the planet, individuals around the world. There's a specific question about Africa. Before we came on, we were talking about India, a little over a billion people of the 7 billion. I think China's probably vaccinated most of their population. But for the first time, the Biden administration is beginning to talk about shipping vaccines that are in the United States, outside the United States. Production by Merck of other vaccines may help the global effort. How critical is this, and how can you imagine this rolling out? I think most countries have been very nationalistic, not just the United States. Most countries have been nationalistic early on. But how do you see this actually rolling out in July and August and September? Preeti, I'll start with you, and then I'll finish with Carlos.
Yeah, and Carlos, of course, has got deep expertise in the global health piece.
Yeah.
I'm just going to say a more general thing, which is that public health is about, like, what I do affects you and what you do affects me. And with vaccination in particular, we're often thinking about our own benefit. Like, I'm going to get vaccinated, so now I won't get COVID. But it really depends on all of us getting vaccinated, and my getting vaccinated keeps everyone healthy. And that's not just true for the United States. We're not like a island in and of itself. We need the rest of the world also to come along on this. And, it is complicated because there's only so much vaccine available right now. I think that these are, and I know COVAX is sort of set up to try to help with that, but it's like a drip right now. I know India is with their Serum Institute. They are vaccinating. They're doing a pretty good job of it. China, Russia, but the EU, but there's a lot of the world left.
Carlos, this is global health has been your life. How do you imagine this rolling out over the next 3 to 6 months?
Howard, I need to go back to my roots, which are HIV, right? And
Yeah.
when we started PEPFAR, when we started
Right.
getting antiretroviral therapy globally, most people said, you can't do it. This will never happen. This was insurmountable. And yet nowadays we have more people. It's the only disease for which you have more people on therapy where the disease is than in the developed world, which is really fantastic. That's what you need. So I think we can do it. We've done it once with PEPFAR. And this is not about charity. As you know,
Right.
full well, global health is about diplomacy. It's about security. And it's about, keeping people safe. And our economy is in the best interest of Americans to get everybody immunized. It's in the best interest of our economy. If we want travelers from other countries to come here and spend their money here, we better get them immunized. If we want them to buy our goods, we better get them immunized. But it's also about diplomacy, and I don't want to abandon that. As the U.S. has retracted as being a global leader, China, Russia, other countries are stepping in, and there's a lot of diplomacy happening right now through vaccines, in which China, Russia, and other countries are giving their vaccines to countries in Latin America and Africa as goodwill and as global health diplomacy. We have to get back in there. That is what the U.S. has excelled on. I mean, I think about going through Africa and people knowing and loving the United States because of PEPFAR. So I really think it's in our best interest as citizens of the world, but it's also, as Preeti said, it's in our best self-interest that we get everybody immunized. So I'm really happy that, President Biden has taken that route and taken it seriously. I want to just say, though, that I really worry about Latin America. I don't want to forget Latin America. It is the region most impacted by this epidemic. We have a problem really seriously right now in Brazil, in Mexico, in Argentina, and Colombia. We have to make sure that in Latin America we get those vaccines. So I just hope that as we start vaccinating the world, Latin America becomes a priority for the United States as well.
This is Howard Bachner, Editor-in-Chief of JAMA. This has been Conversations with Dr. Bachner. Two good friends, Carlos del Rio. Carlos is a distinguished professor of medicine at Emory. He's also a member of our editorial board. And my good friend, Preeti Malani. Preeti is the chief health officer, professor of medicine at the University of Michigan. And I just want to thank her for the extraordinary leadership she's shown in taking over the Peace of My Mind section in JAMA. I think for people who read it week in and week out, her leadership in in surfacing the incredible issues that have arisen in the United States over the last year: equity, racism, structural racism, implicit bias, and the pain and suffering associated with COVID-19 has been remarkable. So Preeti, a personal thank you.
Thank you.
Thanks, Carlos. Thanks, Preeti.
Thank you, guys.
Stay healthy, and I'll see you again in about 2 months.
Yes.
Absolutely.
Bye-bye.
Bye.
Take care.